Welcome to the St Emlyn's podcast. I'm Ian Beardsall.
And I'm Simon Carley.
And Simon, it has been some time since we last talked, and regular podcast listeners who look for a St Emlyn's episode in their feed will have been disappointed for the last few weeks, as we have been, let's just say, a little busy doing some other things. But we are back, and we're going to be talking about the blog posts from April and May do seem a long time ago, in the depths of a gorgeous July, one of those times where you worry about the environment, but also quite enjoy the sunshine. Our garden is flourishing. Simon, how are you?
Excellent. Thank you very much. It is very busy. It's ARCP season. And my work at the deanery means I'm meeting lots and lots of trainees and lots of different specialties, which is great fun, but it does take a bit of time. And next week, I'm off to India to examine for the college. That'll be interesting and fun. People think it's a bit of a jolly, a lot of hard work, but that'll be great. And yeah, just loads and loads of stuff going on. Really busy at work. Lots and lots of poorly people, which is sad for them, but interesting for us. Busy times.
And I've been busy. I'm developing an app, as promised, St Emlyn's, and we're coming up with some other new things. And so I've entered the world of app development, which is a journey of discovery. Me and ChatGPT are spending an awful lot of time together, but I hope to give you some more updates about that in coming months. But hopefully an educational resource where you can use podcasts for enhanced learning, some active learning. And I'm quite excited about it, but it's taking an awful lot of time. Simon, we should just mention a couple of conferences before we dive into the medical content from the blog, because there's a few coming up. And I know that rotas get written far in advance and people will be looking at how they're going to use their study leave. And there's probably three that we'd like to highlight that we would recommend highly. So in reverse order, let's go with IncrEMentum. So IncrEMentum is back in April next year, 22nd to the 24th in Murcia in Spain. We've talked about it a lot on the podcast already, but can't recommend it highly enough. It's a lovely place to go with incredible people. They've added some superb speakers to the already great lineup. So now David Carr, Chris Hicks and Sarah Gray have all been included in that lineup. And it's not even that expensive, even when you've included your flights. So think about IncrEMentum for next April. If you like the snow, don't forget the Big Sick in Zermatt. That's the 3rd to the 6th of February. Again, a conference we're really happy to partner with. And they have some great speakers in that, quite trauma-based, pre-hospital based, always very interesting. And the lure of a Matterhorn, let's just say it is very luring and would be encouraged. And then the last one to mention is the Basics Conference, which Simon, I know you've been involved with and you'll be talking at. And that's the 9th to the 10th of October this year. And that's a pre-hospital conference in association with the Academic Department of Military Emergency Medicine. So lots of stuff going on at that. Have a look, just Google Basics Conference 2025. And you will be able to get involved with those. So plenty of great ways to spend your study leave, lovely places to visit. Do have a look and you'll see some of them, if not all of them, and it'd be great to see you there. And the last thing, just to say a big thank you to the team at the Premier Conference, which just took place in Winchester, the Pediatric Emergency Medicine and Trauma Conference. They've very kindly allowed us to release their talks. So they will be coming up again on the podcast, high impact, short talks. So keep a lookout for those if you're a pediatric emergency physician and interested in looking after children and giving them the best possible care. So Simon, let's dive in and talk about some medicine and some of the blog posts that we published in April and May 2025. We started with a bit of a review from another conference, the IncrEM conference, which I think we've talked about at great length, but worth mentioning again.
Yeah, so that conference will be really good actually, because it's just going to once a year. So it's going to be a big conference and we're trying to do some new stuff and interesting stuff there. So we'll be promoting that quite heavily during the year. The conference this year, it's really good actually. The content was great. There's a lovely talk from Mark Buchanan, who's a good friend of mine, talking about agitation and confusion and difficult problems in the emergency department, particularly around mental health emergencies, which generally speaking, I don't think we're terribly good at. Now, Mark and the Advanced Life Support Group have actually put together something called the Apex course, which I'm desperate to go on. I had a place and I had to turn it down. I can't remember why now, but I'm desperate to go on. I've had really good reviews of it. But they teach a structured approach to the management of mental health emergencies. The course is different because they use real actors. They get people to come in and to basically act through the various different mental health emergencies. And apparently it's awesome. So I'm really excited about that. But he developed many things, have a look on the blog. But what I quite liked about it was the fact that he really emphasized the fact that you need parallel assessments for a lot of these patients. So the medicine and the psychiatry going on at the same time. Gone should be the days, but I know that they're not, where the psychiatry team refuse to see the patient until they've been medically cleared, even though that may take 36 hours and you end up with a patient in distress in the department forever. So that shouldn't be happening. It is championed by the Royal College of Psychiatrists, so you can quote that to your local teams if you run into problems. But also brought in something called the AEIOU approach and how to manage these things with people with self-harm and self-neglect. I quite like it. It's agitation, environment, intent, objects, and you, or unknown, reflect on your role and your safety issues around that. So it's quite good from that point of view. And we had some good talks from the police about how they engage with mental health issues, and of course the changes that are coming with how the police are shifting, or the emergency service, should I say, is shifting the responsibility in the pre-hospital arena from the police being responsible for looking after mental health patients to it becoming a health service issue, and the ambulance service having more role in actively managing those patients in the community. The chap who did it was really good, actually. He's clearly got a good system locally where they have monthly MDTs between people to discuss problems that are going on. So I think there's really good stuff there. There's more about dying in the emergency department. One of our trainees, I went embarrassed by saying, she's got an interest in palliative care in the emergency department. I've met a few emergency physicians like this over the years. And if I was a trainee now and I was looking to make myself interesting to departments in the future, I think developing an interest in palliative care, I think would be really good. We see an awful lot of patients who come through who are on end-of-life pathways or who unfortunately die in the department. I don't think it is niche, but I think we do need people to get out there and champion it. Lots of really interesting stuff in there. Go and have a look at the blog. There's loads more in there. But it's a good example. The IncrEMentum conference has got great content. We're going to do a lot more in terms of the engagement, the entertainment, and the sort of the whole feel of it going forward when we do the mega conference next year.
The management of palliative patients in the emergency department is a real thing, isn't it? That desire to try and do the right thing, but all too often we're in that mechanics of we do everything for everybody. And people just being able to say, no, let's just slow down. Let's think about what we're doing here. That may not be appropriate for this patient. They may not need blood tests. They may not need a cannula. Let's think about the whole patient and what's going on. We have some very active palliative care physicians who have patients on a system. So if they come into the emergency department, they email alert, and all of a sudden they swoop down to the department and they come and, to all intents and purposes, stop us doing stuff. Actually, stopping us doing stuff is probably quite good for patients at times. It seems a good time, actually, to leap to talk about a blog post from Greg about acute behavioural disturbance, as you're mentioning psychiatry, and the use of olanzapine or haloperidol. And this is a paper that Greg's reviewed. Again, thanks to Greg for all the toxicology content that he helps us with, that he writes for the blog. Lots of stuff that we deal with that's really important. And this was a trial, olanzapine versus haloperidol for the management of acute agitation in the emergency department, an open label randomized clinical trial from the Journal of Emergency Medicine, published just at the end of last year.
Yeah, so this is the common presentation in the emergency department. I don't know what it's like with you, but I often end up in a situation where somebody will shove a prescription on my nose, or on a computer now, of course, and say, oh, could you just prescribe some sedation for this person who's got agitation in the mental health area? And I've always been pretty disciplined about it, as the answer is no, until I've gone and seen the patient. I've made an assessment and I've actually agree with it. I'm not sure everybody's as diligent as they should be in this regard. And there's also a bit of concern. So at the high end, we've talked in the past about using ketamine for the patient who've got ABD and they're absolutely uncontrolled situation where you need to get rapid and emergency sedation. That's fine. But there's an awful lot of people who are below that level who still require help, still require support. Going flapping in with ketamine and RSIing them is not the appropriate thing. Drug choices there are interesting. So you can use benzodiazepines, you can use haloperidol, you can use droperidol, but it's not available in the UK. Our American colleagues would be saying droperidol is actually the best drug for all this. Haloperidol, I've used a lot of haloperidol in the past. It was inappropriately and politically incorrectly used to be called vitamin H when I started in emergency medicine. I don't think it should be now. But there are problems, because one of the things it will say is, please could you do an ECG before you give them haloperidol? And you look at the patient and you think, that ain't going to happen, mate. You're looking for QT prolongation because it can cause dysrhythmias. Olanzapine is used quite widely in mental health, but could it be used as a sedation for these patients who've got significant agitation? So this is a randomized controlled trial, which I've got to say is absolutely fantastic to see in toxicology. We very rarely see good quality RCTs there. Quite small, 94 patients with significant agitation with an AMS score more than 3, so that's pre-agitated. They took surrogate consent from a legally authorised representative, again, because it's difficult to do trials in this area. And they either got 10 milligrams of IM olanzapine or 5 milligrams of IM haloperidol. I will cut to the chase. They both worked. So they both worked quite effectively. Average age is 25. And so at 15 minutes, things are getting better. Does take a little bit of time to work. Either is fine. You're probably going to use olanzapine. Side effect profile is safer. So I think that's a good trial. And then may certainly lead me to do a little bit of a change of practice there.
The biggest question for me sometimes is not which drug to use, but who needs a drug. Because sometimes de-escalation and just trying to calm the whole situation down can help. But there are other times where you try that and you think, I'm not getting anywhere here. But I do sometimes, again, a bit like when we dive in to manage palliative care patients with lots of needles, sometimes you think with these patients as well, take a step back, Sometimes security guards taking hands off a patient, just trying to de-escalate. All the other techniques we can use may prevent you having to worry about which drug to use, but there are undoubted some times when you do need some pharmacology to help you get the situation in control. And I think it's really hard in emergency medicine at the moment. We see a huge range of distress, from emotional stress through to the psychiatric, properly unwell, going to end up in a psychiatric intensive care unit. And picking the difference between those along that spectrum is an incredible challenge, particularly when you're busy, you're worried about there's an old lady with a broken hip 2 bays down, and she's listening to this distress. And also people seeing security guards with their hands on a patient, that can be quite difficult. We sometimes forget, I think, the emotional distress for people working in emergency departments about witnessing these things and being part of it. So if there are medications that we can choose and we can be proactive, then can only be a good thing.
You make a good point that we've got to really be careful who we're treating sometimes as well. We may need to sedate patients for the patient's benefit. What we don't want to do is to sedate them for the staff's benefit. Also taking into account the fact that it can be distressing. So there's a real bit of a moral dilemma there and a balance to be drawn sometimes. But of course, in the UK, and I'm sure it's the same internationally, the horror show is the time that patients with acute psychiatric disorders spend in the emergency department. It's not uncommon for me to walk in and find patients who've been in the department for 80, 90, 100, 120 hours. I don't want to spend 120 hours in my department. I just find it distressing just being there. Yeah, it's a tricky one.
Another next post is from Natalie May. And Natalie, I'm delighted to say, will be very familiar to listeners of the podcast and readers of the blog. She's been a member of the Emlyn team from the very beginning. Absolutely delighted that she will also be joining the IncrEMentum lineup in April next year. So bringing some pediatric wisdom into that stage. So if you are into pediatric emergency medicine, please do think to come to IncrEMentum, because Natalie will be challenging us with some thoughts about how to care the best for children and young people. And she did an update about pediatric emergencies from the NUSA conference. NUSA is in Australia. There's a lot in here to take in, really. Far too much for us to cover in a very short podcast, and worth a read. But things like those things that perhaps we sometimes don't pay huge attention to, ENT emergencies, those sorts of things, our duty of care to patients, and how we can best look after children. All topics that Natalie will be covering in greater depth in Spain in April next year. So please do think about coming along and listening to her. She's also a fabulous presenter, one of those people who I've watched and learned from over the years. And she commands a stage like almost no other, and worth the trip almost to see her alone. Simon, you reviewed a paper about the derivation and validation of a simplified bleeding audit trauma score, SBAT. Sometimes it does strike me that when you're applying to do a grant for a trial, one of the most important things is having a decent acronym, and SBAT is right up there with decent acronyms. This is a score to think about how we triage patients who are bleeding. Is it something that we can be thinking about using in the future?
Yeah, I think so. So the BAT score was originally derived, and we talked about it on the podcast a couple of years ago, I think. So people are always trying to find scores that are going to predict death from bleeding or death from trauma in those early stages. And we've oscillated between very much quantifiable data, so things like the shock index, systolic blood pressure over pulse rate, and really qualitative things. So things like the hateful eight. Does your patient look pale, sweaty, air hunger, gasping for breath, and venous collapse, those kind of things. They're mostly qualitative data, because it's really difficult to predict who's going to run into trouble. So the original BAT score used quite a few things: systolic blood pressure, heart rate, respiratory rate, GCS, age, and mechanism of injury. And it was okay. It's actually probably performed better than some of the other scores like shock index and ABC. But one of the problems with it is it requires a fair bit of clinical knowledge to do it, and some testing, which only health professionals can do. So a bit like we've seen with the move in pre-hospital triage for major trauma, where they've gone from things like the triage sit and sort, which required us to take medical readings, to the TST, the 10-second triage, which can be done by anybody. The SBAT is that version of the BAT, and it's designed to be something which somebody could use at the roadside who may not be medically trained. So it's rough age, how conscious they are as opposed to a formal GCS, whether they've got a radial pulse, whether they're tachycardic, and whether they're trapped. So relatively simple things. And they've basically gone back into the TARN database, looked at all the motor vehicle collisions there, of which 3% of those died actually in the TARN database, and decided whether or not it can predict death at 24 hours. Well, what they found is pretty good. So statistically, it's got an area under the receiver operating curve of 0.9, which is pretty good. sensitivity of 96%, which is pretty good, specificity of 72%. So yes, it's certainly something that we should look at. However, it's still a little bit complex to do. Still, you can imagine speaking to somebody over there on the phone and going through this series of questions might be tricky. The most important thing is it's not actually been tested on people. So this is derived and validated through the TAR registry. The statistics of doing that are fine, but all of the data that went into the TAR registry was done by health professionals. So if we're proposing that this can be used by members of the public or other members of the emergency services, that kind of needs to be tested in practice. And it's only use the TARN database, which is specific to the TARN database. Really interesting, still seeking things which work. And who knows what the future is. I think it's going to be a combination of, I don't know, well, you probably do the same, Iain. You look at the numbers, don't you? And then you look at the patient, and between the two, quantitative and the qualitative assessment, you make a decision about whether you're going to give blood, how sick this patient is, whether we're going CT or straight to theatre, whether I'm putting a central line in, whether I'm putting an art line, all of those kind of things. It's always going to think it's going to be a mixture of the two.
And sometimes this is about how you allocate resources as well. So thinking about who you should send a pre-hospital team to is a really difficult decision for call handlers and people in ambulance call centres, I think, where they're wondering about, should this be one of the HEMS patients or should this be, and that opportunity cost of, if I send HEMS to this patient, what about if another patient comes in? That was always a struggle I had when I was doing pre-hospital emergency medicine, was always waiting for the big case. So you sometimes didn't go to the smaller case because just what if I was at this one and then something else happens, because there isn't an ending resource there. The 10-second triage that you mentioned, just if you're new to the podcast or new to the blog, we did do a podcast about 10-second triage with Sean Brayford Harris, who was part of the team who derived that. That's worth a listen. It's only 20 minutes long, and it's Sean talking about how you derive these scores, how you had to work together with lots of different agencies as a paramedic, working with the police and others, and get to the place where you've got a score that can be used. And I think most ambulance services are now using the 10-second triage. So it's something very much worth being familiar with if the worst should happen and you're in an area where a major incident does occur. Every time my children say, "Oh, Daddy, did you see this? Have you seen one of these?" I'm always, after 17 years as a consultant, I will say, I've seen pretty much everything, but the one thing I haven't seen is a major incident. Luckily for me, I know you have been part of them, Simon, but my career has never yet had a major incident, and I'm still on the edge of wanting to be prepared for that. I'm thinking about what might happen, because you never know in today's world when that could end up literally on your doorstep. So worth thinking about all those things. And that trauma score from Tim Nutbeam, the SBAT score, a good friend of St Emlyn's and a highly regarded publisher in this area, is worth a look. Lots these days, Simon, about how we can organise emergency departments. The 10-year plan for the NHS in the UK has just been published. Goodness me, there's a lot in there. Sometimes we just want to think about how we can make our emergency departments work a bit more effectively. And Stefan Bruns is great at the blog post for these. If you're interested in organisational management of emergency medicine, please seek out his blog post. And he's written one for us in May this year entitled Self-Organised Criticality, why your ED is like a sand pile. This gave me pause for thought. Simon, how about you?
Yeah, it's interesting. So the analogy that he's using is the concept that your emergency department's ticking on fine, everything's okay. And then all of a sudden you look around and about half an hour later, things have just gone all over the place. Patients piling up on the corridor, ambulance queuing outside, the waiting time's gone up, the managers are coming down. Oh, what's happened? Has one of your F2s gone for teaching? And that's why the department's fallen over or something like that. So what he talks about is the concept that essentially it's like a sand pile. So if you're doing a sand pile at the beach or something like that, you're dropping sand on the top and it gets bigger and bigger as a pile. And all of a sudden it just collapses and it seems to trigger that collapse. So this is what happens really in emergency care. Our systems almost all the time now are operating near a critical point where even relatively small changes can cause massive disruption. And his point is that isn't actually that rare. It happens all the time. It's expected. And because it can be expected and can be predicted, we should really be working around this. If you look at the data, these sort of avalanches where sort of you get this sudden change in performance, however you're measuring performance, they happen quite often. And just because it follows what's called a power law, not a normal distribution. So the power law thing essentially means that you've got issues around tipping points that suddenly cause this disproportionate breakdown in what goes on. Suggestions about what we do about it. Stefan's very data-led, and I've got one of my colleagues as well who is very data-led on this, and they're incredibly useful people to have in your departments because I have an emotion about things and we have a view about things, but unless you can put data behind it, you don't really get change. Now with the data collections, if you've got a good electronic patient record, you can look at how things go. So you can look at tipping points like hospital occupancy level, where ED boarding skyrockets, we know about that. or when ambulance handover is grind to halt, what is causing those, looking for, and then using that to identify what the early warning signs are, variability, delays through the system, and then look at the connection. Is people looking at the emergency department in isolation and saying, why is the ED suddenly fallen over? And it's not quite the analogy of when a butterfly flaps its wings as a tornado in Texas, but there are things like that. So if all of a sudden one ward goes down in your hospital, which is going to be a critical point that goes through, so say half the AMU goes down due to an infection control and people don't get moved around, it is like the butterfly effect. So what he wants is just to look at how we work, look at things like the weekly cycle, because those are predictable elements, but people don't plan for them. Empower the frontline staff to make decisions, because that's where we can do things. Got to create psychological safety to make sure that people can speak up and learn what we're doing and input into how we make things better. And we've got to learn how we naturally adapt under stress and support people about it. The final line, and I think the most important one, and the one which I think gets missed all the time in hospital, is we in the emergency department, we know when things are approaching criticality. And yet a lot of the systems that we work with don't respond until the avalanche has fallen and the sand pile has gone down. And that, you can call it proactive approach or whatever, but that's what we need to do. So identify what our triggers are and intervene before things go wrong. And that's what I don't see that often. And it's what I don't see speaking to colleagues all around the country, because we're so close to the edge. It's tricky.
There are times when you think, oh, thank heavens, there's only a 4-hour wait to be seen, and we can all just take our foot off the gas a little bit. And the truth is, if you can get down to a 2-hour wait to be seen, you're a bit further away from that point of criticality. But the exhaustion I see and the fatigue I see in colleagues and in departments is real. We know a lot of this. We used to have in Southampton, our critical point we knew was 280 patients in a day. Those seem like halcyon days. It's more like 410 now. But we knew that when we reached 281, somehow that was worse than 279. I don't know why or what would happen, but that was it. We also knew 15 years ago that every hour we needed 7 inpatient beds for admissions. And that probably has just not changed significantly. It's at least that, if not more. But we all too often don't necessarily enact this data stuff that we know, or it's really hard just to keep going all the time. The constant nature of emergency medicine does make it very hard. And so sometimes we find we've accidentally tipped into this point of criticality just because that's the way that day went. But if we have those triggers, and a colleague of mine who, Simon, we know very well, Mike Plancy, did a lot of work about having dashboards which would give you hints about where you were at and how things were going. And it is just so much more complicated than, well, one doctor down. I have to go to a huddle when I'm in the emergency department, and they're useful for lots of things, but often we concentrate on sheer numbers of the doctors that we've got. And having one doctor down can mean a lot, and it can mean nothing at all. And doctors going to teaching, please, if you're in charge of an emergency department, letting your doctors go and have teaching and be fulfilled and educated and look towards being better as clinicians will give you far more value than stopping them going and keeping them on the shop floor for so many reasons. I could do a series of podcasts about it. Please, if you're ever in that position where you think, let's just cancel teaching because the world will get better, that is not true. And actually the world will become much, much worse. So please keep your doctors educated and your nursing staff, all your clinicians. We've lost sight of that sometimes too. And this does maybe perhaps lead us on to Rick's post about compassion in emergency care. Rick did a talk about this at the IncrEM conference. And for a long time, Rick has been reminding us about the word suffering and what it means to suffer. I've used it when I've talked to people. I did it yesterday. I was teaching on a course yesterday. And you know, when you get those things and somebody tells you, oh, the person in bed 4's got some pain, you think, yeah, okay, so have I. I've got a headache. And the person, can you prescribe some painkillers? If I ever find myself forgetting what that means, I just change the word to suffering. And Rick taught me that if you were to be told the patient in bed 4 is suffering, I think we would all go and try and make it better. Words matter. And this is Rick talking more about that, the idea of how do we maintain compassion in emergency medicine when it feels impossible. He's done a huge amount of work about this and trying to ask patients what they want. Because if we've got patient-centered care, then that's probably, I think, a good thing. So there's a lot in here.
There is. I remember years ago, Rick did a study in our department where he really defined suffering as not being just about pain. And it was just basically went out to patients and asked them what was bothering them the most. And it was often things like fear nausea, vomiting, and not just pain. He talks about quite a lot of evidence around this area. So there's a chap called Ergul Kaide asking whether patients who were suffering in ED, and yes, they were suffering pain, anxiety, hunger, thirst. Those are things that are really important. But what they wanted most wasn't just medicines and tests. They also wanted explanation, reassurance, and closure. And so we have to combine these things and go beyond just prescribing 2-cocodamol, which is a terrible drug anyway. He's developed something called the EPIC model, EPICC, and that's to look at this in terms of what is the patient's emotional distress, what are their physical symptoms, what information do they need, what care do they need, basic needs of care from all of us, but particularly focused on our nursing colleagues who are very stretched at the moment, and then closure to bring it all together. I think it's a really good model, actually, and I think it's something I can definitely use in practice. So EPIC, EPICC, we should be teaching this and having a look at it and using that on the shop floor when we're dealing with our resident doctors and other clinicians to talk through what making the patient better actually means. And I think he's got a really nice quote. He says, compassion isn't just a task, it's an emotion. And to feel it, we need to connect with our own emotions first. And that's where self-compassion comes in. If you want to care for others, then you need to start by caring for yourselves. So go to teaching, take some breaks, talk about things which have gone on, forgive yourself from mistakes that have happened, and be kind to yourself as you would be to the patient. And then between the two of you, you can do it. And one of the things about Rick is that he writes stuff down like this, but he genuinely lives it. And he is an absolute pleasure to work with and a proper hero in emergency medicine.
We're very privileged to have Rick on the blog. He's so busy that sadly he's not able to write too much for us these days. And I know he's got big news from his career coming up, which I'm sure you'll all hear about soon. It's his news to tell, but it's big news and we're delighted for him. But he is a proper legend, one of our original professors of emergency medicine who continues to walk the walk as well as talk the talk. This course I was teaching on the other day, I've learned with my medical school work that medical students have for some years now been taught to always ask patients about ICE, ideas, concerns, and expectations. And I've racked my brains to try and remember whether I was taught this as a medical student. And I don't think I was, but it seems that everybody is now. If you're younger than me, you'll be familiar with this idea that we should ask patients about their ideas, concerns, and expectations. And again, this is all part of it. Why did you come to the emergency department today? What were you worried about? What did you think was going to happen? Because if we don't know that, if we don't know what the question is, we can never provide the answer. It's just a guessing game. So every time I see a patient now, I'm absolutely focused on why today? Why did you come and see us today? What was the thing that's worrying you? You seem to have a really mild headache. I don't understand why on earth you would come to us today. Oh, your dad's just been diagnosed with a brain tumor. Okay, I get it now. Those simple questions and asking those and understanding those is probably much more important than being able to reel off the 7 causes of clubbing or the other things, the knowledge base that we try and plow into ourselves to be the best doctors we can be. So always remember, keep the patient at the heart of it. What were their ideas, concerns, expectations? And then EPIC, just to remind you, emotional distress, physical symptoms, information, what patients want to know. Care, simple things. And remember, this is not an only game for nursing staff. This is something you can help with. Some of the times, my most rewarding points of an emergency department shift are getting somebody a blanket because they're cold or getting them a glass of water because they're thirsty. Such simple stuff. And then closure, talking to a patient about what's going to happen next. These are the things where we can make a difference. Simon, coming to the end of some of these blog posts, we will do a special episode on your talk that you did at IFEM about the top 10 trauma and research papers. Although we've covered a lot of them separately on the blog and in the podcast in the past, I know those episodes are really popular. So we will be going through all 10 of those papers. But just before we come to an end, you did a blog post about emergency centre thoracotomy in South Africa. I've never had the privilege of working in South Africa. We've had all sorts of different things on the blog about what it's like to work in particular other environments. And the experience of our colleagues who are working in places like South Africa is something we can learn from. But this is a paper from Chia Evans, who again was part of the Badien team, a great friend of St. Emlyn's, and Craig, her husband. And this was always talking about thoracotomy in South Africa.
Yeah, Kat's the senior author on this one, and it's Sitman who's the first author on this one. But it is from their unit, which is Mitchell's Plain Hospital in South Africa on the Cape Flats, which I've been to a couple of times now. Quite a remarkable place. It was a huge privilege to be shown around there by Kat some years ago, and together with Craig, her husband. And then we went out and visited the 2 locations which this paper is about. And I've got to say, at the time, I was astounded back then about what they were doing. Now, remember that this is not a trauma centre. This is this is equivalent of a DGH in South Africa, where this study basically the studies around emergency centered thoracotomy. So give you a bit of background about the geography. I hope I get this right. So Mitchell's Plain is in the Cape Flats. It's a hospital. It's got surgery on site. It's got intensive care on site, but it's not a big trauma centre. And then in the community, they have a standalone emergency department, which is something we don't really see in the UK. So this is a sort of a large shed type structure, and it's quite nice, where people can come in, and there's a short stay ward, but no on-site surgery. And so this is the experience over 4 years of the thoracotomies they've done in both of these sites. 67 emergency centre thoracotomies, 50 stab wounds, 17 gunshots, and didn't do any for blunts because probably didn't work. And also most of their patients there are sadly penetrating trauma. They're young, 25 years average age, and 2/3 of them arrived by their own transport, which I think is, we used to call that the bromobile, where your bros come and drop you off at the front door. Had a few of those over the years, some fairly significant ones, and one of which did end up in a thoracotomy, but it's obviously much more common there. 80% of them arrived with signs of life, and that's going to be a key finding in interpreting the study. Most of the thoracotomies were done by resident doctors or junior doctors who have been trained how to do a thoracotomy, but they're not surgeons. They're not cardiothoracic surgeons. They're not pre-hospital emergency physicians, trained consultants or anything like that. These are junior doctors who are performing these. What do you reckon? What do you reckon the survival rate is for these patients who require this? So they've collapsed they've been brought in, quite a few of them got signs of life, and then they subsequently die. And they get a thoracotomy, 24% of them go home, 1 in 4. Which is just an incredible number compared to the outcomes of thoracotomy for penetrating trauma in the UK. The thing is, it dovetails really quite nicely with some other work that we've seen this year from London Air Ambulance about their experience with thoracotomy over many years. And what they've shown is that if you have your thoracotomy soon after collapsing, then you've got a very high survival rate. Their numbers, if you collapse in front of them, are possibly the same, if not better, than the numbers that we're seeing here from South Africa. And the key is that these patients are arriving with signs of life, and they're arriving quickly because they're not necessarily waiting for the ambulance service to bring them in. These are relatively small areas, high density of problems, but they're basically being brought in at a really rapid pace. We saw this again in a paper that we've reviewed on St Emlyn's from, I think, Philadelphia, where there is a system there which, if the police turn up at a penetrating trauma and the ambulance isn't there yet, they put the patient in the back of the police car and drive them to hospital. And they've shown there that these short on-scene times and rapid movement to hospital for these patients with time-critical bleeding, thoracic and abdominal trauma, they do much better. This paper is telling us the same. So it's telling us that if you get to hospital quickly, if you get a thoracotomy quickly, you've got a good chance of survival, 1 in 4. I think it's amazing results. The most important thing is just the doctors and the clinicians that I met in South Africa are epic. The circumstances they work under, their speed of learning, their ability to manage this kind of trauma, early parts of their career is remarkable. And hats off to the authors of this paper and everybody else who's working in places like here and doing this work. And of course, remember that Stefan, who we talked about already, he used to work in South Africa in the Cape Flats as well. And he has a lot of experience with this sort of thing. Remarkable medicine.
Lots to take away, aren't there, really? And for me, the question is always about when should you be doing a thoracotomy? We curiously wait for the patient to get incredibly unwell before we start thinking about doing something, even though we know it's about to happen. We sit and wait, okay, we've lost the pulse, let's open the chest now. And clearly time is the factor here that makes a big difference. But yeah, imagining what these doctors are doing with the whole team, because this will not just be single individuals, this will be a whole team. And remember, this is not a major trauma center. This is working in a hospital that's, to all intents and purposes, not designed for this. 67 patients over 4 years. That's over 1 a month. Imagine if your emergency department was seeing more than 1 thoracotomy every month. You would be really thinking quite hard about what you had to do for that. But this is great stuff. And it's such a delight to be able to read this from South Africa and also to know Kat and her team and what they're doing. And again, part of the power of FOAMed and what's happened over the last decade is getting to know people. I'm sure if you reached out and wanted to chat to Kat about it, she's a lovely person. And her contact details will be in the paper, and she would be very happy to tell you a little bit about her experience. And if you ever get the chance to hear her speak, or Craig, they're great. And hopefully one day, BAD-EM, the conference I was booked to go to, it was ruined by a small thing called COVID. And I was about to fly to South Africa and take part in BAD-EM. Disappointed that we weren't able to for lots of reasons, but hopefully one day. that will come back and we'll be able to go and see the team down there. Simon, that is a marathon for us, much longer than normal. We've got to make the most of us both being in the same room. I won't tell you what time of early morning this is, but we've had to do it early to fit in with all our schedules. And hopefully we'll get to record again very soon. There'll be more coming up on the podcast, and keep an eye out for all of the different things we talked about, all of those conferences. Try and book your study leave now. Simon, travel safely to India, and our best wishes to all the emergency physicians out there. Good luck to everyone if you're doing an exam, whether that's in India or in the UK or elsewhere. I know how stressful they can be, and look forward to talking to you again on the podcast again soon. Take care.